good morning, good evening, good afternoon, wherever you are catching us from. I am Pastor Dr. Cassandra, and welcome to my YouTube channel where we get wisdom and we get understanding. And in doing so, we help a lot of our patients. And so, in this video, we're going to be talking about ectopic pregnancy. All women of reproductive age are pregnant until proven otherwise. And it is an ectopic pregnancy unless we demonstrate that it is intrauterine. So one of the challenges that is there when it comes to ectopic pregnancy, as we're going to see, throughout this video, is that the best thing is to diagnose ectopic pregnancy early. So if you find yourself in a place, let's say there are no ultrasound machines, and just the diagnosis of ectopic pregnancy, maybe it's difficult because of the lack of equipment, of expertise, the best thing that you can do is to assume that all women of reproductive age that come to your clinic or your hospital are pregnant, unless you prove that they're not. Okay, and it's also best to assume that that pregnancy is an ectopic pregnancy unless we prove that it is not. So what is an ectopic pregnancy? So an ectopic pregnancy, this is a flaw in human reproductive physiology, where the conceptus is implanted and it matures outside the endometrial cavity. Ultimately, it leads to the fetal death. The fetus will not be able to grow because of the different in the space where it's implanted. There's no enough space, and without timely diagnosis and treatment, ectopic pregnancy can become very life-threatening. And so from the word ectopic, right, it means outside or in a location which is not normal. So you find that this is a pregnancy which can be in different spaces, and we're going to look at that. And so what is the incidence rate for ectopic pregnancy? According to our research, 1 to 2 out of every 200 pregnancies is an ectopic pregnancy, and this number is increasing. Some of the reasons why this number is increasing is that the diagnosis of ectopic pregnancy by the use of beta HCG. Okay, so there's now ways of detecting ectopic pregnancy early. Okay, there's also the use of ultrasounds. Okay, that identify the location of the pregnancy. Also, some more reasons why there's an increase in the number of ectopic pregnancies is one, there's an increase in sexually transmitted tubal infections, okay, like PID. And so because of the increase in that, the risk of having an ectopic pregnancy has actually gone up. There's also an increase in assisted reproductive practices, okay, such as IVF. There's also early detection of ectopic pregnancies. So with the development of ultrasound scans and different ways in which we can be able to detect ectopic pregnancy early, this has led to an increase in the number of ectopic pregnancies. Then there's also what is known as tubal sterilization. There's been an increase in that, and because of the same, there's an increase in ectopic pregnancies. Contraception use is very high, and it is a high risk for ectopic pregnancy, such as the use of IUCDs. What are some of the other risk factors for ectopic pregnancy? So, one, a previous ectopic pregnancy. So, the recurrency of ectopic pregnancy is about 10 to 20%. So, if a person has had ectopic pregnancy in the past, they will find, they have a higher chance of them having another ectopic pregnancy. Another one is infections such as tubal infections. Okay, our classic example being a PID, a pelvic inflammatory disease. A person who's had a previous pelvic or tubal surgery. A person who has subfertility or assisted conception, okay, such as the use of IVF. A person with endometriosis, the use of IUCDs. Okay, but I'd like you to note that 33% of women with ectopic pregnancy will have no non-risk factors. So it can just happen, and we cannot tie it to any of the risk factors that we have described or that we have talked about so far. So this ectopic pregnancy, remember, this is a pregnancy which is outside the endometrial, which is outside the intrauterine cavity. So what are some of the sites where we can find ectopic pregnancies, and how common do ectopic pregnancies occur in those sites? So the first is the ampulla, okay, which takes about 80% of the time. An ectopic pregnancy, you find it in the ampulla. The isthmus, okay, which is 12%. The fimbriae, 5%. The corneal, 2%. The abdomen, 1.4%. Ovarian, 0.2%, and on the cervix, 0.2%. So what are the signs and symptoms of ectopic pregnancy? How would somebody know, or how will your patient present if they have ectopic pregnancy? So ectopic pregnancy has what is known as a classic triad. So when you look for, when these three things appear in a patient, you should start thinking ectopic pregnancy. 1, abdominal pain, amenorrhea, and vaginal bleeding. So a patient can present with any of these. Your patient can come with a history of not having her menses, and now suddenly has PV bleeding and abdominal pain. So what do you do when you're taking a history? So ectopic pregnancy will present with the normal symptoms of pregnancy, like nausea and vomiting, tenderness of the breast, plus or minus dizziness. It also comes with severe vaginal bleeding, sudden onset of cramps, and repeated urination. So, as we've said, the common signs of pregnancy: breastfulness, nausea, painful fetal movements, because the space in which that fetus is growing is smaller than the normal. There's dizziness and weakness. This can be, again, secondary to a patient having bled a lot, and they might have shock, fever, flu-like symptoms, vomiting, syncope, and cardiac arrest. All these can be symptoms and signs that we find as we take our history. Yeah. So what are the differential diagnoses for ectopic pregnancy? So ectopic pregnancy must be differentiated from other causes of lower abdominal pain in a woman of reproductive age or PV bleeding. For example, a similar condition that can manifest like ectopic pregnancy is abortions, okay, a bleeding corpus luteal cyst, an ovarian cyst accident, appendicitis, or pelvic inflammatory disease. So with all these differentials, we can now go to our physical examination, and we see what we are going to look for as you do your physical examination on your patient. So your general condition, if the patient has been bleeding for a long time, they may present with pallor and sweating. Okay, and these are signs which are pointing more towards hypovolemic shock. Okay, when we look at the vitals can be normal. They can also be tachycardic, which is above 100 beats per minute, or the patient can also be hypotensive. Okay, they have a BP of systolic less than 100, diastolic less than 60, and these are pointing towards the more acute or severe form of ectopic pregnancy. Most likely in this case, the ectopic pregnancy has ruptured and the patient has been bleeding. When we do our per abdomen, okay, on your abdominal examination, you find that the uterus usually has a normal size. There is unilateral, bilateral lower abdominal tenderness, rebound tenderness, or peritoneal sign may be elicited. This is due to irritation, especially if there's bleeding. There's irritation to the peritoneum. When you do a vaginal examination, we find that the cervix is closed. There is cervical excitation and adnexal tenderness occasionally, and we have rarely you can find an adnexal mass. So what are some of the signs that are suggestive of a surgical emergency? Like, what are the signs that if you see them, it should click in your mind that this patient most likely would like surgery because of a ruptured ectopic pregnancy? One, abdominal rigidity. So if the abdomen is rigid, okay, involuntary guarding, severe abdominal pain, evidence of hypovolemic shock, okay, like orthostatic blood pressure changes or tachycardia. Okay, it means patient has an emergency. In that particular case, that ectopic pregnancy has ruptured, and the patient should go into theater and you should operate. So now that we are able to take a history, we're able to do our physical examination, and we know what we're looking for, what investigations would you do to help you lean more towards the diagnosis of ectopic pregnancy? So under our investigations, there are some bedside investigations we can do. If your patient has come with PV bleeding, abdominal pain, history of amenorrhea, you are thinking it's ectopic pregnancy, one of the things that you can do is, especially if you think it's a ruptured ectopic pregnancy, because remember, that's an emergency. So we do what is known as chordocentesis, okay, where we go with a needle through the posterior fornix, okay, into the pouch of Douglas, and we aspirate. So if there is bleeding, okay, you'll be able to aspirate the contents of the pouch of Douglas. And then what do? You take that blood, put it in a vial, and then we do clotting time. So if the blood is within the pouch of Douglas, right, it means it would have mixed with peritoneal fluid. And now what happens with peritoneal fluids when it interacts with blood is that blood loses its ability to clot. So you'll find that the clotting time is going to be more than 15 or more than 5 minutes, okay, which is going to be pointing more towards a ruptured ectopic pregnancy. You can also do some of your labs like gravity index, okay. We do full blood count with differentials. We're going to check for the HB. We're looking for mostly on the full blood count with differential count. We're looking for the HB, white cells, red blood cells as well, to help you know if the patient has been losing blood for a long time. You'll be able to see. Then we do serum beta HCG, which is going to be it won't be increasing as much as it should, because when it comes to beta HCG per week, it's supposed to double. Okay, it's supposed to double in a normal pregnancy, but in this case, it will still be there, but it won't be as much as we are expecting it to. Then we have our imaging investigation, which is an ultrasound scan, and we can also do a laparoscopy, which is the gold standard for ectopic pregnancy. So what will we see on an ultrasound scan? It's most useful in demonstrating an intrauterine pregnancy, and it's able to show adnexal masses. It may also be possible to see an adnexal gestational sac with free fluid in the pouch of Douglas, which is suggestive of a ruptured ectopic pregnancy. So even as you can see in this case, we see there's free fluid in the pouch of Douglas. We can see an early gestational sac, okay. We can see again free fluid in the pouch of Douglas there, which is suggestive of the presence of blood, okay. So the definite ectopic pregnancy, okay, when it comes to ultrasound scan, is that one, you'll find in the presence of a definite ectopic pregnancy, okay, you will find a thick, brightly echogenic ring-like structure, which is located outside the uterus, with a gestational sac containing an obvious fetal pore, a yolk sac, or both. So we can see there's a uterus there. This is where we're expecting the gestational sac. But we can see that outside the uterus, there's a gestational sac with a fetal pore over there, which is suggestive of a pregnancy, but this pregnancy is outside the uterus. Okay, but this finding is unusual. A spectrum of what you will be able to find, which can be suggestive of an ectopic pregnancy. Okay, number one is what is called a tubal ring. A tubal ring. So you can see within the tube, okay, within the fallopian tube, you will see the previous description that I just gave. Okay, you can see a yolk sac, and you'll notice that instead of this being in the uterus, you'll find that this tubal ring is found within the space where you should see the tube. So that will be suggestive of an ectopic pregnancy, which is in the fallopian tube. You'll be able to see an adnexal mass. Okay, so for example, we can see there's an ovary there. Okay, and this is the adnexal region, but there's a sac with an obvious fetal pore, and this is outside the uterus. Okay, another thing that you can see is an interstitial ectopic pregnancy. So you can see a fetal pore in a yolk sac with a fetal pore within the wall of the uterus, not in the cavity, but within the actual interstitium. Lastly, we can see hemosalpinx. Okay, this is the presence of blood in the pouch of Douglas, okay, which is again suggestive of a ruptured ectopic pregnancy. So now that we're able to detect ectopic pregnancy or diagnose it, both a clinical diagnosis and when we do our ultrasound scan, how do you manage ectopic pregnancy? So the management of ectopic pregnancy, one, it depends on several clinical pictures, the scan results, and the levels of beta HCG. Okay, tubal pregnancy can be managed by laparotomy, operative laparoscopy, medically, or expectantly. The management must be tailored to the clinical condition and future fertility preferences of the woman, and also the management of the acute ill woman differs from the management of a common presentation of ectopic pregnancy. So let's go through that and we're going to be done. So firstly, let's look at how we can manage an acute presentation of ectopic pregnancy. The question is, how would you know the patient is having an acute manifestation of ectopic pregnancy? Okay, in this case, we're saying there's a ruptured ectopic pregnancy. So one, the clinical picture will be that your patient is going to come in pain. Okay, the patient is going to have tachycardia, hypotension because of the blood loss. They'll have other signs of shock like cold, clammy skin, okay, drowsiness or dizziness or fatigue. Your patient can also have your patient will also have a positive urine test, okay, a positive pregnancy test. With that in your mind, you're thinking it's a ruptured ectopic pregnancy. So the acute symptoms are due to the fallopian tube rupturing, and there's need for urgent resuscitation and laparotomy. So the main management in this case is laparotomy. So there's a partial or total salpingectomy, okay, where we open the fallopian tube and clean out and remove the pregnancy. Secure hemostasis, remove blood, okay, and make sure that we also clean any clots which would be in the abdominal cavity. How do you manage a subacute presentation of ectopic pregnancy? What would be the clinical picture? So here we have a positive urine test, clinical signs of ectopic pregnancy. There's pelvic tenderness, there's cervical excitation, shoulder tip pain, and an empty uterus on ultrasound scan. So we carry out diagnostic laparoscopy, which can be optional. If ectopic pregnancy, laparoscopy, laparoscopic salpingectomy or salpingotomy would be then appropriate. In a hemodynamically stable woman, operative laparoscopy is preferable to laparotomy. Okay, instead of making a big scar, we can just do laparoscopy where you use the instruments and there are only there's minimal incision. Thirdly, how do you manage an ectopic pregnancy in a woman who is well? The clinical picture will be there's a positive pregnancy test. The uterus is empty on ultrasound scan and no clinical signs of an ectopic pregnancy. So what we want to do is to check the quantitative beta HCG, repeat after 24 hours. If an ectopic pregnancy is likely, then the woman remains asymptomatic. We can do medical management. Okay, we can do medical management of ectopic pregnancy. If there is decreasing beta HCG and the woman remains stable and asymptomatic, then we can also manage this woman expectantly. So we are waiting for any changes. Again, this is optional. So what is the medical management of ectopic pregnancy? Ideally, we want to give a medication which stops the rapid growth of cells. Remember, this is a pregnancy, so the cells, okay, or the conceptus is growing rapidly, and so we can use medication such as methotrexate, which is given as a single dose of 50 milligrams per kg per body surface area, okay, or 1 milligram per kg body weight, which is given on day 1. Then we give it on day 3, okay. If we notice that the beta HCG is greater than 5,000, okay. So on day 2, day 4, day 6, and day 8, we give leucovorinic acid or folinic acid. Want to measure beta HCG on day 4 and day 7. Want to give another dose of methotrexate up to 25% of cases. If the decrease of the beta HCG is less than 15% on day 4 and day 7. So from the time that you give your first dose, we give leucovorinic acid. On day 4, day 7, we recheck the beta HCG, and if we notice that if it's not reducing at a certain rate, if it's not reducing more than 15%, then we want to give another dose, and this usually happens in about 25% of the cases. The woman should be given clear written information about adverse effects and the possible need for further treatment. The pregnancy should be avoided for at least 3 months after the last dose, as methotrexate is teratogenic. Some of the less common sites where you can find an ectopic pregnancy and how to manage, okay, in the cervix, in the ovary, in the in the C-section scar, interstitium, okay, of pregnancies need expert input, and so therefore there's no universal agreement on how we manage such uncommon cases, but generally the preference is to do medical management as long as the patient is asymptomatic and stable, and surgical treatment is reserved when there's a clinical need. And in this case, you need experts, you need obstetricians who you will consult, and they'll be able to give specific guidance for this patient. Thank you so much for joining. Go and save lives. All the best, and see you in the next video. Bye bye. Of note, we have another channel called More Music Notes. So different parts of this lecture are going to be turned into songs, so you can go there and listen and you'll be blessed by them. Thank you.